All right. Hey, everybody. It's Becky Pearson with Destri Millsap from Pivot Point of View. And today we're going to talk about hip pain, rider hip pain, anterior hip pain, labral issues. We have been seeing quite a few of that. Uh, Quite a few of those diagnoses come through the clinic and in the school. Have had people reaching out to me about hip pain. Young girls that the doctors have said that they probably need to go have surgery, but they're not really wanting to have surgery. So I thought this was a very timely discussion for us to have here on the podcast. And what are you seeing, Destry, in the schools?
Yeah, we've been seeing more and more of them with our runners and everything. And there's been a few of my friends that when they ride, they've had hip pain. And a lot of people will write it off as like groin or hip flexor strain or something like that that just never gets better, never improves. And we're finding underneath of those, they've been having a hip labral issue.
Yeah. And, sometimes it's kind of hard to diagnose a labral issue. They typically don't show up on x-ray, right? Um, are you seeing girls go in for x-rays or they jump into the MRIs pretty quick? What are you seeing?
Well, when we refer them to our orthopedic surgeon, and he takes a look at them and determines they'll take an X-ray just to make sure of the joint space and look to see if there's any stress reactions, or mainly just to see how their joints look as far as like is there any deformities or impingement type issues, things like that. Is there any decreased space? Some of the congenital stuff that we've seen, like the head of their femur is too big for their socket, and a lot of those people will see bilateral tears on both sides. So it just kind of depends on the situation, but a lot of the time they'll catch it, they'll order the MRI and get the MRI read so we know what we're dealing with.
Yeah, diagnostics are always helpful, no matter what. It helps us treat as a provider, and it kind of gives you an idea of what you're dealing with. Now, that doesn't mean that you are your MRI. I like to tell people that even though, you know, say for example, I have an older lady that she came in for prehab, and she's getting ready for a total hip replacement because she's had a labral tear for so long that now she has bone spurs developing in her hip. But even though we know this on the diagnosis, it still doesn't necessarily always change what I do, because I look at range of motion, I look at strength, and that isn't going to change per se. Knowing that it's a labral tear or not a labral tear when you go off of your clinical findings. It is helpful to know that for sure to maybe avoid certain things, but it's not necessarily um, the end of all things if you end up having a labral tear and oh my gosh, there's nothing we can do. There's a lot that we can do for those people, don't you think?
Yes, and what you said about doing the evaluation and you're basically just treating their symptoms. Where are they limited in their range of motion? Where are they weak at? And addressing those areas first, because no matter what, you're going to have to restore those, whether you have a hip surgery or not. So as they go through this injury, I've seen more people now have the surgery than I have in the past. A lot of the times, most of those hip labral issues, depending on their symptoms, they would allow them to do PT first and see how they progress. And then if they didn't progress, they would have surgery after. So more and more, we're seeing a lot more early operative stuff to get that fixed and get them going down the road.
Mhm. Yeah, and I think a lot of it depends too on like where are you? Like you're in a pretty good orthopedic area. Like there's a lot of orthopedists in, I'm assuming in the Tulsa area, bigger city, there's a few more options. Now we're out here in the middle of Nebraska, and there aren't a lot of doctors in central or western Nebraska that want to even touch a labral tear. They'll refer them to Omaha, Lincoln or Omaha to fix that labrum. And my theory on that is in the past, there's not been a lot of great surgical outcomes with um, whether it's prior surgical techniques or maybe the knowledge of, what rehab we have to do afterwards and what do we avoid and what do we do. Um, have you seen a change in that in your career so far, like how you managed labral tears postoperatively, and then how, like, have you been seeing better outcomes lately with it?
What we've seen, people have been making full recoveries. And just like a shoulder labrum, even though the hip is obviously shaped different than the shoulder joint, when you have a labral tear, that is not going to repair itself. You have to get that surgically repaired in order for it to completely be better. And then the more that you let it go on, then the worse it'll be down the road and more wear and tear there'll be and stuff like that. So the people that have been fixing them, being diligent with their rehab, following the protocols, I mean, we've been returning them to full function at a high level with our athletes. And so right now with who we have doing the surgeries and everything else, they're doing a great job. And again, a lot of the stuff that I would see earlier in my career was non-operative. We would just treat the symptoms, range of motion, strength, things like that. As their symptoms decreased, we would progress them back to activity, and we were having success with that, but it took a lot longer. And in the horse world, people aren't going to want to take time off. And so when you say surgery and things like that, they don't have the time to take off for these surgeries. And they're like, if you tell them, hey, we can probably rehab through this, whatever, they're going to choose that option every time.
Yeah. And I do think there's a lot of things that we can do, whether it's to buy some time until they can get to a slower season. Like a lot of these girls that I've talked to, they're thinking, you know what, this is springtime. I want to be able to compete on my horse through the spring and summer and fall, and then I'll go get something done in the winter, which is that's fine. You have to do what works for your situation. And there are things that we can do to help these girls, or well, I keep saying girls because it happens a lot in young women, I feel like. And so help these people like just manage the pain while they can get to a slower time of their life. Don't you think, Destri?
Well, people don't realize that this is a pretty common injury. A lot of people do have a hip labrum issue. They just don't have all the symptoms all the time.
Yeah. And I think whether you opt for surgery or you don't opt for surgery, it's really important to restore that range of motion and strength. Let's talk a little bit about, I don't have a pelvic model with me, but let's talk a little bit about what a labrum is and what I'm going to share my ideas on the mechanics of it. Feel free to disagree with me if you want. But if you think about the hip is a ball and socket joint, okay? And so your hip sits up in the socket that's in your pelvis, and this is your thigh bone. And basically, your labrum is the rim of cartilage in that hip joint that helps cushion it, helps keep it, make it a little bit deeper. When you set the hip ball up in that and it rubs to the front, it's going to wear on that labrum more and then eventually get a little bit of a tear, which then causes pain, impingement, things like that. And so I feel like it's that head of that femur that stays too far anterior or too far forward that creates a lot of pain and problems with that. So, my approach to treating these patients, the very first thing that I like to do is I like to look at their hip internal rotation. I want to see if they're limited that way. Um, and then I like to, if I can get my hands on them, I like to, take them up and check, like bring their knee up towards their chest and across towards their opposite shoulder. A lot of times that's like an active impingement move for the hip. Um, and then I want to see what their reaction is to that. Um, I don't know. I just like it's so much of a feel, like when you're assessing these hips, like I feel like the hips that I run across in the clinic that are having labral issues, I feel like they usually have too much external rotation and not enough internal rotation. And I don't see these patients being able to shift to the back side of their hip. And so those are the things that I go after when I treat anterior hip pain. So what I end up doing, you know, whether it was this older lady that is preparing for hip surgery or a young gal that I get in the clinic, I look at the hip range of motion. I also look at their feet. I want to know if they're pronating too much, because if they are pronating too much and we don't control that, when those feet collapse, those thighs internally rotate, the hips internally rotate, and I feel like you get more pressure on the front of that hip. Yeah, I think it's really, you have to look at the whole picture. You know, you have to look at the hip mobility, you have to look at the strength. Usually, I think that these folks are usually weak in their hamstrings, their adductors, glutes. I mean, it's just, those are kind of the common ones that we see with most anything. And I totally agree on the pelvic position too. Like I feel like if they are more anterior on that side of their pelvis, or maybe on both sides of their pelvis, you're going to be more likely to have pressure on the front of that hip joint. And so restoring the pelvic position is important. And I think getting them to the back side of that hip joint. And so I'll have people do a lot of hip shifting, whether it's sitting or whether it is standing. So I just did a Zoom call yesterday with a gal from Minnesota, and getting her to shift to the backside of her hip. And you know, it's not going to, I don't feel like it's going to hurt her hip. Definitely is a way to possibly help it and to get her through until she can get to a slower time of her season. Um, so ways that I do like hip shifting is like a really simple one that you can do. Like most of you are, well, I shouldn't say most of you. Some of you might be sitting, like driving while you're listening to this. And so one of the things that I have my people do, because sitting can really irritate a labral issue, is have you sit and shift your left hip and knee back so that your left knee is behind your right. If you look down at your knees, you would see your right knee is further ahead than your left. And then I would have them pull their left knee in. So if you're driving, don't let your leg flop out against the door. Okay. So how many of us do that when we drive? I bet if you're sitting driving your car right now, you look down, probably your left knee is pretty darn close to that driver's side door. So it's a great way to get you to shift to the back. You just got to scoot that side of your hip back. You pull that knee in and you engage that left inner thigh. Now, how many times have we talked about left inner thigh weakness on with different topics? I mean, we talk about the inner thigh a lot, don't we, Destry?
Yeah, especially in equestrian athletes and doing my own eval, I have left adductor weakness, poor left hip internal rotation, and I've seen that in some of my clients as well. And once you open those things up, it's like it immediately feels better and they can sit down in their saddle better and have that strength coming out of the barrel and out of the box better too with that adductor strength.
Yeah, so I've been working on my commute. I've been working a lot on getting my hip shifted back and pulling it in. And actually, I'll even do like when I'm on cruise control, I'll just kind of squeeze both knees together to work on my inner thighs. It's isometric exercise while I'm driving. Why not use that time to get stronger instead of just weaker and more deconditioned? So that's one real simple thing that I do with people. And then there's a whole series of things that I do with them. In clinic or via Zoom. I can do that to get people to kind of shift to the backside of their hip, because I feel like whether you go through surgery or not, we still need to get the posterior capsule or the backside of your hip opened up and get you to shift to the back of it. Otherwise, you're going to continue to have anterior hip pain problems and not have great surgical outcomes.
Going back to what you said about foot position and stuff like that, with the functional movement screen stuff that we've been doing with our rider performance, we're able to identify some of those areas that might affect everything down the chain. Like when you do a squat, if your feet turn out or if they turn in or if you pronate in the squat, we can identify areas up the chain that are causing that, whether they're tight or weak or whatever. You know, if their knees cave in and their feet pronate, we know how to fix that. And so I think just identifying things in because we are functional athletes. And so and during the movement is important to being able to fully fix them as well.
I agree. Totally agree. And it's just been interesting to me as I've dealt with, as we've talked before, I've dealt with some hip pain this spring. And when I don't wear good arch supports, or, I love my Hey Dude shoes, but they're no support whatsoever. And so I get my orthotics in there, and it surprises me how much of a difference when I wear good shoes with good support, how little hip pain I have. And then if I go a couple days without the good supportive shoes, how much I start to feel my hip bother me again. So that's a really important part of it too, just improving, I think, the lower extremity mechanics.
I think the best way is just working on your prevention and early detection and getting evaluated for what type of deficits you might have by doing the functional movement screening, checking range of motion, checking strength, and addressing those areas early so that you don't have to deal with this issue.
I agree 100%. If people get to us early, we're much more likely to be able to fix the issue and get them on the right path versus just waiting, hoping, praying that it's going to go away. That usually doesn't fix the problem. Now, you might have periods where you have more pain, less pain, but the underlying issue is probably still there. So I think getting some help early on, whether it's would they do a Zoom call with us and do a evaluation, or finding somebody in their area to be able to help them knowledgeably about this. I think it's very important. If we're trying to help somebody, I think about there was an analogy of a doctor that he was a cardiologist, and he felt like when he was in cardiology, he was standing at the bottom of a waterfall trying to catch people to save them. Like their lives had already just spiraled out of control, and he was their last ditch effort to save them. And so if you think about, are we going to be at the bottom of the waterfall trying to catch these people to save them, or can we get to them further upstream before they ever get to the waterfall? I think if you can get help early on, let's get you upstream so you never get to the waterfall in the first place.
And that's also important for the wear and tear aspect. Early detection, getting the right diagnosis, getting the right referral, getting the MRI, figuring out what it is, how bad it is, if it needs fixed. So then as you go on down the road, you're not predisposed to having an early hip replacement or having so much pain that you can't do what you need to do on your horse or in your sport, whatever it is that you're doing. And getting a functional evaluation so you can identify what maybe caused this issue. If it wasn't a traumatic injury, obviously trauma is a different story, but if it's more of an overuse type injury that caused this labral tear, which we see quite a bit, finding the root causes of that in your mechanics is key. So you make a full recovery, even if you have surgery, and getting all that stuff addressed. And basically, you're looking to strengthen all the muscles around the hip, stabilize the hip, and don't forget about the core too. You have to strengthen those core muscles around it as well so you can achieve and maintain pelvic neutral. Because in pelvic neutral, all of our stuff will move how it's supposed to. And we can address muscle tightness and weakness and stuff like that. But pelvic neutral, everything will move how it's supposed to move. And so it's just our job to try to maintain that.
I agree. I agree. And if it is, if somebody's listening to this and they think, gosh, I wish I would have heard this stuff, 20 years ago when I started having hip pain, and maybe they are thinking about a hip replacement. The other thing that I wanted to bring up is to look for a surgeon that is using an anterior approach versus a posterior approach. I've had some people that have went through hip surgery and they went with a posterior approach, and I really feel like the recovery is so much longer. They usually have a lot more hip precautions. It's a lot more traumatic to the joint itself. And so if you want to hear a little bit more about the anterior approach, a few years ago, I did a interview with Dr. Sextro. He's in central Nebraska, and he uses the anterior approach. So we talked about that a little bit as well. So you can go back and on the podcast or the YouTube channel, we have those available. But, hopefully we're getting to you before you have to go through the surgery of a hip replacement. But if you do have to go through either a labral repair or any other kind of surgery, we definitely need to be thinking about making sure that the position of the hip and pelvis are in the best place possible before and after surgery. And also ask your doctor about rehab, because some of these doctors also are not doing physical therapy after they do a joint replacement. And so that's really disheartening to me, because I feel like it only will make their surgery look better. But you can definitely ask your doctor. Don't feel like you can't ask for it. But you can be an advocate for yourself, or visit with us about what to ask the doctor about, and we can help you with those conversations.
And
So
these injuries are not the end of the world. Just like with any injury, with the stuff that we've been seeing, addressing the range of motion and strength, we've had good outcomes non-operatively and operatively. So don't be scared to go get it checked out, figure out what's going on. If you don't want to have surgery right now, that's fine. At least put in the work on your rehab so your hip will last as long as you need it to before you can have that next step in your care.
I agree. Anything else you want to share?
No, I
All right.
don't
Well,
have
we'll
anything.
wrap it up for today. And as always, let your health be the pivot point to your success, right?
Absolutely. Thank you, everyone, for listening.
Thank you.